Hi, everybody, and welcome. I am Eileen Thrower. I am the Department Chair for Midwifery and Women's Health here at Frontier Nursing University. It's really wonderful to see everybody tonight. I'm really excited to have so many of you joining us for a very interesting presentation this evening that is going to be provided by Dr. Ann Schaeffer. To tell you a little bit about Dr. Schaeffer before she gets started, Dr. Schaeffer has been teaching for over a decade, mentoring and precepting undergraduate and graduate students. She's currently an assistant professor here at Frontier Nursing University, where she teaches and mentors DNP students in their quality improvement projects. Dr. Schaeffer practiced midwifery in Virginia for 22 years, and she is a two-time midwifery practice founder. She has directed programs to improve access to contraception, colposcopy, perinatal care, centering pregnancy, and depression treatment for diverse and multicultural communities. But tonight, Dr. Schaeffer is going to be presenting the sixth vital sign to us, strategies to integrate, standardize, and normalize depression care. We're really excited to have you, Ann, and thank you so much for joining us tonight. And I'll turn the floor over to you.
Thank you, Eileen, and it's so nice to be here and to see so many familiar faces, and I want to welcome everybody. As Dr. Thrower said, I'm Dr. Ann Schaeffer, and I'm joining you tonight from Harrisonburg, Virginia, in the Shenandoah Valley, on the land of the Shawnee and Monacan people. And I also want to wish a happy Yom Kippur to those who are celebrating, and let you know that my pronouns are she, her. And so let's get right into it. I don't have a whole lot to disclose as far as my affiliations, but as Dr. Thrower said, I am a professor here at Frontier Nursing University. And a lot of what I'm going to be talking about tonight was actually the focus of my quality improvement doctoral work. It's a topic that has been near and dear to my heart for years, but I really found how this can be integrated into nurse practitioner and midwifery care and more effectively care for our clients. So that's what I'm going to be talking to you about tonight. Here are all of our various objectives. I will not read those to you, but they are there. And now I'm going to just get right into it. So what is so important about depression screening and care? To tell you a little bit more about my own evolution on this, in my life before midwifery, I was pursuing a doctorate in counseling psychology. And so one of the things that I loved about midwifery, and I think about advanced practice nursing generally, is the opportunity that we have to really care for the whole person, that we are caring for their mental and physical well-being. However, I didn't have a real framework for how to bring depression care into my regular practice and make it work as a normal part of my practice until I really dug into this on my doctoral work. And so I'm going to share today some of what I learned about that. So why is depression care so important? Here's some of the background. So I can tell you that the economic burden in the US of depression each year is estimated at around $210 billion. Worldwide, depression is our leading cause of disability. We know that depression often goes undiagnosed and untreated, and this is even more so for our non-white, non-cis het folks, immigrants, and refugees. And we also know that depression is higher and more likely to happen in people with comorbid conditions and chronic illnesses, so asthma, diabetes, things like that. But there's more. Healthy People 2030. This has been, depression screening and care has been on the Healthy People goals and targets for decades, and it continues getting carried forward because we're just not getting a whole lot better at it. Right now, they found that only 8.5% of primary care office visits included depression screening, and that's for people ages 12 and over, and that was in 2016, and it hasn't changed a whole lot. On the Medicaid adult core set, depression is the fourth least reported measure. And I included the Virginia statistic here just because this is where I'm from, and this is information that's pretty available in all states. But for example, here in Virginia, for people who seek care through our health department, the lifetime incidence of depression is 82.6%. Now, anything that happens over 80% of the time is it's more the norm than not to have had depression at some point. And we know that here in Virginia, over half of adolescents and adults who have depression did not receive any treatment within the last year. So why don't providers screen for depression? Why aren't we just doing this all the time? And maybe if anyone wants to quickly type into the chat, why are providers just not right on this? Why do we have such a hard time integrating this into our regular care? Anybody have any ideas? Just throw them into the chat box, type them right in. Yes, I'm seeing time, anxiety about how to treat, lack of knowledge, stigma. Yes, absolutely. Lack of resources for referrals, time crunch, yes, exactly. And there's one person who says, we do it for every patient, and that's fantastic. It's uncomfortable. It's someone else's problem. Yes, it's hard. This is very hard. So I want to just acknowledge that. And these are all, the fact that these were all very front of mind, I think tells us that this is not an easy thing. But I do want to remind all of us here that we are routinely screening for all of these things and much more. So the lifetime incidence of hypertension is 45%. That's lower than the lifetime incidence of depression. But we get blood pressures taken all the time. You can't go to a dental appointment without getting a blood pressure checked. So we are screening for blood pressure, hypertensive issues all the time. Obesity in the US right now has a 42% rate, also lower than the rate of depression, but we are getting weight on people. We don't always calculate a BMI, but we're weighing folks all the time. Another one, hypercholesterolemia, 26% lifetime risk in the US, but I think we are pretty comfortable suggesting to people that we might want to get a lipid panel. So I just want to challenge us all to keep in mind that we do screen for lots of things all the time, comfortably, routinely, and we have gotten so normalized with these that clients don't think anything of it when we bring out the blood pressure cuff or ask them to step on the scale. Actually, sometimes clients do think about it when we ask them to step on the scale. So I don't want to just treat that in a cavalier way, but we're pretty automatic with a lot of our screenings, and we're pretty good with initial next steps when we see that some of these screens are positive. So the U.S. Preventive Services Task Force recommends that all people age 12 and older be screened for depression when systems exist for adequate diagnosis, treatment, and follow-up. And that's really important. I want to just point that out. The recommendation actually goes on to suggest that if you do not have systems in place for diagnosis, treatment, and follow-up, that screening alone is actually possibly harmful if you're not prepared to go to the next step. So that's something to kind of be challenged on. Screening is not evidence-based care. We're not doing enough when we just screen. Interestingly, just as I was working up the slides for this presentation, the USP STF also just came out with a brand new recommendation for anxiety screening that is remarkably similar to this right here, that also suggests that for folks ages 12 and older that we are screening for anxiety. And I'll try to mention that where it's relevant here in this presentation. Okay. So screening for depression, as I said, is not enough. Only when diagnosis, treatment, and follow-up occur do clients demonstrate significant improvement over time. So this is the part that I would say as a practitioner, I always felt like I knew how to screen, but I did not have in my toolkit that piece about the diagnosis, treatment, and follow-up. And so I'm hoping tonight I can give you all a few more tools to put in your toolkit to consider that. So I want to, because it's National Midwifery Week, and this presentation is part of our National Midwifery Week here at Frontier, I do want to just say that this is an opportunity for midwives and also for nurse practitioners. But for midwives who are here tonight who might be thinking, this really doesn't feel like it's in my scope, I want to say, yes, it actually really is. We have core competencies as primary care providers, and I am just going to go out on a limb here and say that lots of you who are midwives or nurse practitioners probably function as primary care providers for a lot of your clients. I would hazard to guess that lots of your clients who come to you are very comfortable with you and probably come to you more than they come to another separate primary care person. We have some brand new ACNM standards for the practice of midwifery, and Standard 2, midwifery care is composed of knowledge, skills, and clinical judgments that foster the delivery of evidence-informed, client-centered care. So that is well within what we're going to discuss tonight. So what I'd like to introduce you to, and some of you may already be familiar with this, is the SBIRT concept. Stands for Screening, Brief Intervention, and Referral to Treatment. If you want to type in the chat, has anyone here worked with SBIRT with any other kinds of client conditions or use the SBIRT approach for any other kinds of presenting concerns? I'll give people just okay, SBIRT on admission to L&D. Interesting. Yeah. Okay. So alcohol and yes. Okay. So yes, Tristan, that's exactly. So yeah, L&D admission. Very good. So the SBIRT approach was first developed as a way to identify and treat substance abuse. So it's a really, but it's a framework that's been applied to other chronic health conditions with success. And SBIRT processes with depression demonstrate improved outcomes. So there are key characteristics to an SBIRT approach, and I've listed them here. So it is something that is brief. It's the whole thing can be done in 5 to 10 minutes. It's comprehensive. You can complete all elements, and it's universal. So everyone who is eligible are screened and offered care. So I'm going to use that framework to talk tonight about the steps that you can take and start thinking about taking, or if you're already doing, maybe augment how you are caring for your clients who may be at risk for depression. So we're going to start with the S, the screening. And when we're talking about depression, we really want to use a tool. The research is very clear on this. Providers who rely solely on clinical judgment to diagnose depression, instead of using a standardized screening tool, underdiagnose depression significantly. And I cannot emphasize that enough. So it's very important, and we have great tools that are available to us. We don't have to reinvent the wheel. So the two I'm going to talk about are the Edinburgh Postnatal Depression Screening and the Patient Health Questionnaire. These are often referred to as the EPDS or the PHQ. So there are pros and cons to both of these tools. The EPDS, it's available in over 12 languages. It has 10 items, with number 10 being your suicidal ideation item. It does have a validated anxiety subscale, which is interesting. You have questions 3 through 5 that you can score separately as for anxiety. The EPDS is specific to perinatal care. So if you are in a practice that is primarily perinatal, I think the EPDS is a really solid tool. This is the one that I have seen used in our in some of the practices I've been a part of. And it's got guidelines on scoring, and it lets you it basically presents this as a form that you can utilize. And like I said, 12 languages. Now, the PHQ is available in over 20 languages, and it has 2 items initially. And if they score positive on those 2, there's an additional 7, so a total of 9. Number 9 is your suicidal ideation item, and it is effective for anyone age 12 and older. And it is valid with a perinatal population as well. So this could be an interesting option if you have a population who spans all ages or all genders, or if you see perinatal, but you follow them into the GYN a lot. Sometimes the PHQ has a broader application. For folks who want a anxiety screener, this does pair well with the GAD-2, the generalized anxiety disorder screener. It's again a 2-item questionnaire with 7 if they score positive. But again, 20 languages. This one is, and that's available online, and it's super easy to print out. So one thing I want to say to you, whatever screening tool you use, and that's totally up to you, I do want to remind all of us to consider the client in front of you. It does give us categories in which to screen people, but one person's 6 might be another person's 15. I actually found that quite a bit when I really researched and studied this. It would take me aback sometimes, especially folks of different cultural backgrounds or who spoke in different languages other than English, that they might score a lower score, but then report quite significant impact on their life. So I wouldn't avoid treatment or withhold treatment just because somebody's score doesn't reach a certain threshold. I would really also use your clinical judgment. So when are you going to screen? So the U.S. Preventive Services Task Force suggests wellness visits, and when it's been greater than a year. ACOG and ACNM suggest new OBs 28 weeks and the postpartum. The U.S. Preventive Services Task Force also suggests that if you have somebody who's being treated for depression, that you screen them when you see them. And then, of course, if they have verbal or behavioral signs and symptoms of depression. Now, one thing I want to say about these first 2 items, wellness visits and greater than 1 year. One of the barriers that I found when I was implementing my doctoral research, I was working in a very busy federally qualified health center with a really multicultural population. And we saw tons of people all the time. And it was the standard for them to screen for depression at the annual wellness visit. And yet their screening as a center was hovering around 9%. So why was that happening? So I've did some digging, and what I learned was that, probably like so many people, clients at that FQHC, they didn't really come in for their wellness visit. They came in when they were sick, they came in when they needed something like a refill on a prescription, and they never really scheduled a wellness visit. So this very literal team was looking at reason for a visit and seeing, oh, they're coming in for, dysuria, and didn't matter. They hadn't been in for a year, but they were coming in for dysuria. They never got screened for depression. So we had people who had been in for 14 visits over 3 years who had literally never gotten a depression screening done. And so I just want to remind you all that if it's been more than a year, even if you've seen somebody multiple times for other things, but they've never had that wellness visit, throw a PHQ or an EPDS in front of them. It's time. They need it. So how do you find the time? There's a few different suggestions that seem to work well for the majority of practices. So it can be part of the standard rooming procedure, and that's kind of on the nursing team, whoever is rooming clients, that they are rooming them and presenting them with the PHQ or the EPDS. Some practices also have the ability to get this done in the waiting room. It's given to them when they check in, and they're either given an iPad or a paper tool. And then the other thing is you can do it right in the visit. And in fact, this is probably, now that I've worked this into my practice, this is probably the way I end up doing it the most. You do need your forms and your pen or pencil in the exam room. you might not be, but you might be amazed at how much of the time a screening isn't going to get done if you can't find something to write with. You'll just be like, we'll do it the next time. So have something to write with in the room. And I used to have a notebook of different languages of PHQs because I worked in a really multicultural community, and I would be able to pull out the Tigrinya PHQ or the Russian PHQ, depending on the language of my client. And I had some scripts that I use that I've written here. So if I just want them to go through and complete it, I might say something like this, like, I'm going to step out, let you complete this form and get ready for your exam. Or I'm going to look over your history and read about your last visit. Would you fill this out while I do that? Or if it's towards the end of the visit, maybe I'm going to say something, while I complete your note and send this prescription, would you answer these questions? And so you're getting it done. You're making it just a very quick part, like standard, like we just do this. We do this all the time. The other thing I want to say is the next important thing is that you get into the chart that you did the screening. It's very hard to know if they're due for screening or if they should or shouldn't have screening if it's not being documented. So I would suggest that you have a template for a screening that was positive and a template for a screening that was negative. The ICD-10 code for depression screening is up here on the slide, Z13.89. So you drop that code for getting the screening done. This is not the code you use to diagnose depression or other mood disorders. We'll get to that in a minute, but you do want to drop in the code for the depression screening. That is actually the way that you can both document that screening happened, and it's also how you get reimbursed. That you can get reimbursed for the screening. Okay. Overcoming challenges to getting screening done. Have all your supplies in the room or at the front desk or wherever you decide that screening is going to happen. Consider, if you do pre-clinic huddles, adding in depression screening as something that you want to flag people for, like who's due for it this morning. You know, in our clinic, we had a model like that for flu vaccines during flu season, who's due for their flu shot. And you could review it as a team. EMR templates to document the process. Those are things that can really help you. Now down here, there's going to be a couple times in this presentation where I'm going to fully acknowledge that we could probably spend an entire multi-hour program just on the cultural stigma and barriers around depression care. And we don't have that tonight, but I do want to just acknowledge that this is huge. One of the biggest lessons that I learned from my team, not from the research, but then when I learned this, I found it was echoed in the research, is that you really want to avoid verbal screenings for depression. This was brought to my attention when I was starting to look into how we might do this effectively. And the person who I give complete and total credit to for this was the lead interpreter in my clinic. And she and I were talking about getting depression done. And she said, you know, when somebody comes in and they are, you know, often coming in with their children, or maybe a neighbor drove them and came back in, you know, walked back with them, or their spouse is with them. And you ask about depression, it can be very uncomfortable. It can, in some cases, even be offensive. You aren't going to get an accurate answer. And I said, oh gosh, okay, so what do we need to do? And she said, you really need, if at all possible, to do a written screening. And when I told my team that that's what we were going to do, there was a great outcry that they were worried about literacy with this very multicultural community. And I said, you know what, let's just see what the literacy is and what the literacy barriers are. And I see a question about that in the chat, actually, about what if there is a client who can speak a certain language but can't read it. Well, I will say, first of all, that over more than a year of implementing this type of care, even more than a year, really, of doing this care with a really multicultural community, I did find that if I had a PHQ in their preferred language, almost always they could read it, almost always. My team's concerns about literacy were way inflated. Most people that had that were here and had made it to our community were literate in their first language. However, I will get to that. If a client does need to be screened verbally, I would use that only when there's no other option. But if you do need to do that, I would try to find a time to do it when there are no other people in the room. Use the exact language written on the tool. One of the things I observed, I watched my team doing verbal screenings because that had been a previous practice. And the most well-meaning people will put their own spin on verbal questions. They'll say, "You don't feel depressed, do you?" Or, "I've got some questions I have to ask, it's required," whatever, And I think that goes to our own discomfort and our own stigma around depression and mental health care. And so if you have to do it verbally, it just needs to be read exactly as written on the piece of paper, and you do your best. You just do your best. All right. So we've done the screening. Now we're going to move into the brief intervention. So this cat, my patient screened positive, now what? So I know that for some people, this is how people feel when they have a client who screens positive for something like depression. They're like, "Oh God, what am I going to do?" So let's talk about that. So first of all, you want to have some sort of standard verbiage that you use to explain that result to the person. And I say something like this: people with scores like yours are often dealing with depression. And I say it really matter of fact. I try not to say they're often dealing with depression like I'm delivering cancer news. No, I'm wanting to tell them that, yeah, this is often kind of what's going on. If it is a very severe depression score and the client in front of you is perhaps exhibiting symptoms, this has been kind of a key thing for how I've thought about this. Consider that the visit might need to be about the depression, not the original reason for their visit. So if the person in front of me came in for their annual and their PAP, but they score a 22 on the PHQ with a positive suicidal ideation, I no longer feel that getting their PAP done that day is my primary role. I feel like with the client's consent, maybe we spend our time talking about this result and what they might need. I wouldn't do it without their consent to do that, but I do think that sometimes that's the better use of the time. And then what really makes the brief intervention part of your role as an NP or a midwife work is being able to utilize a shared decision-making tool. So shared decision-making has a lot of benefits. This is well supported in the evidence. When clients feel like they are part of their treatment plan, they're really more likely to participate in their treatment plan. So they come to the follow-ups, they keep their referrals, they stick to their meds, they're honest with their provider about how they're doing, and they're just more satisfied with their care. One thing I do want to be clear about with shared decision-making, shared decision-making is appropriate when there are true evidence-based options in the approach to care. This is not a situation where we get consent and allow somebody to decline care. People are always welcome to decline care. But shared decision-making really is, there's a few different paths we could go down here. So let's talk about that together and come up with a plan. And depression care is actually an area where shared decision approach really works and really, really makes sense. So there are so many shared decision-making tools. And the great thing about these is if you have these in your exam room ready to go, you do not off the top of your head have to give a spiel about how we're going to treat your depression. So the Mayo Clinic decision aids are a great one. Option grids is a great one. There's a whole lot. And what I like to do, and what I recommend other people do, is you literally pull one of these out, turn it so that it faces the patient, and you go through and you say, I'm going to walk you through some of the options here, and we're going to put circles around the ones that are interesting to you. You can ask questions. You can take this home with you. It's very similar, in fact, to how we discuss things like contraceptive options, where, again, that's a great example of shared decision-making, where there are literally many options somebody could choose, and you are helping them navigate through that. And a lot of us, without realizing we're doing it, use a shared decision aid when we do that. Maybe we have a form or a graphic with lots of different options. So I pull out my shared decision-making tool. I use that to talk through the options with the client. And I'm going to reiterate this again. We could spend hours on this topic alone. Racial, ethnic, and cultural considerations. So every cultural group is going to attach a slightly different understanding to mental health, depression, and treatment. Actually, every individual does that. Shared decision-making is a chance to understand what the client in front of you thinks about these issues while preserving dignity and choice. It is very important to remain in the conversation with our clients. So even when I don't understand why somebody might be making a decision they're making, or they are choosing, I'm going to go back a minute, watchful waiting when they are positive for their suicidal ideation, I'm still going to walk through all the options, and I'm going to say, tell me more. Why? Tell me more about your feelings about therapy. Tell me more about your feelings about medication. What does that mean to you? Where are your concerns? And I might even say, we might not arrive at the answer you want to arrive at today, but I want you to keep thinking about it, and I want permission to follow up with you. I would like to bring this up again. I want us to keep talking. And I'll talk a little bit about that in the treatment part of our SBIRT here shortly. Okay, brief intervention. The last thing we want to do, just like our screening, is we want to document. We want to choose a diagnosis, and we want to write what the patient's chosen plan of care is. Okay. This slide has a lot of different words on it, but it is something I use. It's from the Community Care of North Carolina Adult Depression Toolkit for Primary Care. It is the CCNC Adult Depression Toolkit, has great resources. There are lots of toolkits, though, with depression resources. And this was a laminated ICD-10 reference sheet that I would keep in the office. And so it really walks you through, is the depressed mood, has it persisted over a 2-week period? Okay, choose from these. Has it been present for most of the last 2 years? Okay, choose this one. So it helps you. We don't want you to have to come up with these off the top of your head or scroll through. We want you to have some tools, because your time is precious. Okay. Common challenges to this brief intervention. It can feel like it takes a lot of time, especially until you get some automatic functioning on it. Probably the first time you ever walked a client through their decision-making around contraceptives, it took a long time. But as time went on, you got better at it. You became quicker. You got more adept at steering through it. And you use tools. Some people say they're already doing it. They say, I talk to my clients about depression. I'm doing the thing. Some people think my clients aren't interested or won't understand. We shouldn't, that's an assumption. It's impossible with a language barrier. You may have to get an interpreter involved. You may have to get some of your shared decision tools translated into the top most common other languages. It's not productive. I'm losing money. So how might we overcome these? So the evidence really does not support spontaneous shared decision-making moments for depression care. Using a standardized tool and a shared decision-making tool specifically is really key. And if you do that, it's going to only really add a few minutes to the visit because a lot of that information is going to just be presented right there. Clients who are engaged and who realize they have the opportunity to make choices, they really are interested and they do understand. And the research does support that. And that has downstream impact of fewer no-shows and more follow-up appointments, which can increase revenue if you work for a practice that is motivated by the bottom line. I do recommend using templates for documentation, having your shared decision-making tools already in the room in more than one language if needed. Make sure all your team members know about this tool and can offer it to clients. You know, if you have a really on-the-ball team who rooms somebody who got their PHQ done in the waiting room and they see as they're rooming them that PHQ is scoring higher, they might just the empowered team member might just pull out the option grid, put it down in front of the client and say, you know what, Anne is going to talk to you about this when she comes in. I'm going to let you go ahead and look at it. And that's great. And then, of course, always remember that this can be an option to revise the appointment time and reschedule that PAP test or that annual physical. Maybe we just really need to spend 20 minutes today on this mental health care. And they may be so thankful because it literally may be the first time that anyone has put that forward as a priority and has taken the time to care about that. Okay, so the last step of our SBIRT is this referral to treatment. And this is the one that I think a lot of folks have trouble wrapping their head around. And what does that mean for depression care? Our goal, of course, is remission of depression. We want people to get better. So the evidence shows us that without an evidence-based process, remission rates are only about 6%, spontaneous remission. However, a really evidence-based SBIRT plan, you can get a 20% remission rate in as little as 8 weeks and even higher than that with more time. So we're going to talk a little bit about how that might look. So there's some different options. So referral to treatment, that language may mean literally referring out of your practice. And we'll talk about that in a minute. But it also might just mean we're referring you into the treatment process and I'm going to manage it for you. So you've got some options here. Like I said, watchful waiting with timely follow-up, lifestyle modifications, medication, counseling, or psych referrals. I put a caveat for that. Know your community resources for counseling and psych referrals, not only who you can refer to, but also what their time frame looks like. If you have resources in your community, but every single one of them has a 6-month or more waiting list, that is not going to be a great referral option for that client. So know whether that is a practical option. And then, of course, I want to just say here, always consider safety. Verbal contracting for safety for suicidal ideation. Make sure clients are aware of after hours resources, on-call, emergency rooms, things like that. And those, by the way, are all mentioned on your shared decision-making tool. So when you've done shared decision-making, you are queuing up this referral and treatment step. So the midwifery scope of practice for treating depression, and I would posit that this is very similar to any advanced practice nurse. Things to consider. Consider your experience. Is this something you're already doing? Is this something you've dabbled in? Is this something you've got other people in the practice doing so you can sort of pick up from them? Or are you new? And that's okay. What are your options for getting some continuing ed training or access to resources? You're all here tonight, so yay. Typically, I'm going to suggest that the client who is most appropriately managed by a CNM or NP is somebody on no more than 1 to 2 medications. Someone with polymeds for their mood or behavioral health probably is not appropriate. It's a little out of our scope. We if somebody is showing improvement and making progress, I think that's a very appropriate client for us. And no psychotic features. I would just, those would be referrals that I would do off the bat. I want to say something about the perinatal period, and this is a little bit of a convoluted statement, but women who are cared for by midwives have a 20% incidence of depression or mood disorders, whether we identify that or not. And but when they are identified, 80% don't want to engage in treatment. And what I mean by that is 80% did not want to go to counseling or take medication. However, pregnant folks who were more likely to receive treatment when they were offered it by their midwives. So even though it may be that you'd have a lot of people declining meds and declining counseling while they are pregnant, when we offer it, when we talk about it, the number of folks who do consider that, it does improve, it does go up. So we don't want to leave those people without care. I showed this earlier, but I want to put this slide up again to remind you that this is within your scope of practice. But this statement at the bottom is what I want to say. Even if you refer all your positive screens out, screening and shared decision making are still key parts of your scope of practice as a midwife. Okay, and now I'm going to spend a few minutes talking about prescribing, the prescribing step. We do know that for people with moderate to severe depression, the path to recovery goes quicker when treatment is multimodal. Now, that does not mean that everyone has to choose that, but I do tell my clients, I'm like, you have a score that puts you in the more moderate to severe range of depression, and the evidence does show that medication and depression, counseling, and lifestyle, if you can do all three, you may feel better faster. So I do tell them that, and then if they are open to a conversation about medication or they desire to talk about medication, then I want you to be able to take that next step. So if you're just getting started, if you're just considering adding depression care to your scope, clients who are already on medications are a great client to start with. If somebody is generally satisfied with their medication, it's very reasonable for you to take on prescribing that for them, or to modify dosing if they're on something that otherwise is working for them. I can't tell you how many people I saw during the most active phase of the pandemic who said, you know, I've been taking Zoloft for 3 years and it's just not working anymore. I have so much depression, I have so much anxiety. And it was, you know, I'm like, it's the middle of a global pandemic. You've been on 50 milligrams for 3 years. What do you say we go up to 75? And, you know, it just, sometimes it's just a little modification, episodic life events. So that's a good way to get started or dip your toe in the water, is if you just want to start helping clients get like at a more effective level, but they're otherwise satisfied. If you've got somebody who, you know, after going through your screening and your shared decision making is interested in a new start for their meds, your SSRIs or SNRIs, most are clinically comparable. You do want to consider lifestyle, med history, likely side effect, and cost. And I usually talk about first medication for depression, sort of like I do a first time combined oral contraceptive pill user. I say, you know, we're going to try this first pill, and in a few months, we're going to meet back and see how you're doing. And it may or may not be the one that we stick with. You know, we might go through 1 or 2 before we land on the right one, and really just normalize that. Like, that doesn't mean the med failed or you're not good on medication. It just, we may need to find the first one. This is information available on UpToDate, but I pulled some of it to show you here. This would be some of my just off the cuff recommendations for specific cases. So your pregnant or postpartum client, a new start medication, I'd consider Zoloft. Pregnant or postpartum, not a new start. Someone who's already on, maybe a Prozac or a Wellbutrin and they're happy on it, I would keep them on those. In most cases, maybe just adjust the dose. You do want to wean off benzodiazepines for pregnancy, so we don't want to continue Xanax. And so if somebody has depression with a strong anxiety component and you're taking away their Xanax, you may need to bump up their dosing a little bit on their SSRI or SNRI. If they're not pregnant or planning, you've got all kinds of options here. I would say for comorbid substance abuse, somebody who's interested in cutting back on their alcohol or their tobacco, consider Wellbutrin. If they're worried about libido, I would go with Wellbutrin or one of the SNRIs instead of the SSRIs. Chronic pain, Cymbalta can be an interesting one if somebody has a comorbidity with musculoskeletal pain. That can be a nice one. If somebody is pretty anxious, I would be cautious about Wellbutrin. It can sometimes exacerbate the anxiety component. Okay. And then you want to be real matter of fact with people. Again, I'm going to call back to the oral contraceptive pill model. Medications all can have side effects, especially when we first start. They vary a lot, but most do improve with time. Here's a few of the ones that, you sort of see possibly the most. Zoloft can have some real lower GI stuff. Paxil, some dry mouth. Prozac, sometimes difficulty with sleep. Celexa and Lexapro, very rare, but the QT prolongation is a possibility. And all SSRIs can be associated with decreased libido and anorgasmia. But I will say for everybody that notices that, there's 10 people that actually never had a problem and feel like it's fine. I would recommend that when you're writing that prescription, especially for a new start or you're changing to a new pill and you want to give your client their prescription, you want to start low and titrate to symptom remission, especially for somebody who is a little hesitant or leery about medication. The worst scenario is to be taking medicine and not have it help you. So sometimes people are unwilling to take a therapeutic dose, and I'll say, look, we want it to help you. Like if you've decided to try meds, let's try to get you to a place that helps. So here's an example with Zoloft. I might say, okay, let's do 25 milligrams for 2 weeks, and then let's go to 50 milligrams Q day. And then we're going to follow up in 2 to 4 weeks until you feel like you're at a good place. So anticipatory guidance, super important. What could you expect from side effects? Would it be better to take it at bedtime? Would it be better to take it first thing in the morning? Encourage it with food if they have a little tummy upset, and that they really could start to expect to feel some improvement within 2 to 4 weeks, with reaching maximum improvement usually within about 12. So really giving people some idea of where this is likely to go. Frequency of follow-up. This is really key. And I think if there's any step in the process that was eye-opening to me when I really learned about the evidence-based approach to this, was that most of us do the frequency of follow-up wrong. A lot of us, I don't know how many of you all on this in this Zoom tonight have either done yourself or seen other people write a prescription for depression medicine, give the client a 3-month supply or a 6-month supply and say, let's follow up in 3 months or 6 months. As I'm going to show you in a minute, that is not the recommendation of anybody for how often we should be following up when we are doing depression care, especially for acute episodic depression. The great thing about already being familiar with a screening tool and working it into your practice is that using repeated measures of that screening tool is a great way to document response to treatment or worsening symptoms. And it can also help you with knowing when you should really consider changing to another medication. So if you have really given it a good, I would say 6 to 12 weeks, and the client in front of you is still got persistent stomach upset, or they're just not feeling better, that would probably be one I would consider. But if you give them a 3-month supply, you're not going to know that if they're struggling at 6 and 8 weeks. So this is one set of guidelines. This comes again from the CCNC Depression Toolkit, and it's based off the U.S. Preventive Services Task Force. But you can see that even for the mild level of depression, consider watchful waiting with follow-up. Follow-up should be via phone call or visit within 4 weeks, at which point you should be repeating the PHQ-9. So even with a mild depression, we don't want to go more than 4 weeks without checking in on that client. And it can be a phone call, but a follow-up in-office visit is great if that can happen. Some of the more serious levels of depression, if you've got a phone call, if you've asked for permission to call them in 2 weeks, follow-up visit in 4 weeks where you repeat the PHQ, and then after that another visit at 8 weeks, and then at week 12. And you can see here at the bottom the healthcare effectiveness data and information set recommends that there is an initial visit plus 3 follow-up visits in the first 12 weeks of treatment for acute depression. Those are all billable, and those are all evidence-based. So if you are managing depression, it's very important to also tell the client, like, I really care. We're going to see each other frequently for a little bit. And that's how it's going to go. Potential barriers. I just want to acknowledge this is really hard. I think that a lot of us, do have implicit bias, stigma, discomfort. I encourage you to start with refills and treatment of mild symptoms, and just keep repeating, this is within my scope. This is within my scope. Documentation, tracking, and follow-up. Again, create templates, screen often, watch the trend. Just as we would watch the blood pressure trend on a hypertension patient who we had just started on, labetalol, if they come back for repeat visits, similarly, we're going to track that screening score and follow up at shorter intervals than maybe you've done in the past. Language, cultural barriers, try to really get, all of your tools in your primary languages, use your interpreters, and remain in the conversation. If somebody really isn't understanding or seems very distressed, ask about that, be curious about that. Try to find out more about what is going on. We really need to normalize depression care. We need to really think about our own beliefs and biases, and think about how we've handled other aspects of care where biases are common. I think as you do it more, we all develop sort of elevator speeches to to dispel myths and misconceptions. The idea, for example, a lot of people might be concerned that depression medication is addictive. They will become addicted. And I can talk very frequently with people now and very frankly about, you can sometimes have side effects when you come off it, but you aren't going to have a physical dependency. This is not a narcotic. You're not becoming an addict. And if they're still concerned about that, okay, so maybe we're going to circle back to the shared decision-making and look at some of the other options. Really consider that you need a chronic illness model here. This is not personal weakness or failure. Absolutely not. Remain curious. You want to maintain an open-ended and creative inquiry, and really try to get your team invested and on the same page so that everybody is using the same language and the same matter-of-factness when they talk about this. Whenever we are working with any SBIRT process, interventions that are respectful of cultural variation and engage our stakeholders, so again, that shared decision-making, are more likely to result in positive responses. And I'm just closing with this image. I always wondered why somebody didn't do something about that. And then I realized I am somebody. And so I would just encourage you all to think about what you might add to your practice and all the clients who already rely on you, and how you might be able to do this for them as well. And these are my references. And I'd be very glad, we've got a few minutes, I'd be very glad to take questions, or I see one in the chat right now. Any thoughts on genetic testing for susceptible treatments? And that is interesting. I'm not familiar with that, have not been down that path, but that's certainly something, it sounds very interesting. I know that not everybody is financially able to do genetic testing. I do know that sometimes is a barrier for people in terms of cost. But anybody else have any questions, comments, reflections?
Dr. Schaeffer, there's another question. Is the PHQ-2 a validated screening tool, and are you recommending the PHQ-9 instead?
So the PHQ-2 is valid as a screener. So as long as, if it's positive, you follow it with the additional 7 questions of the full PHQ-9, that can be one way if time is very tricky. If you want to initially give clients the PHQ-2 and then just proceed to the 9 if you get a positive. So it can be done stepwise. I've seen it. It is effective in either way.
All right, thank you. Another one which I think you've addressed, but I'm going to read it to you to make sure you don't want to add anything. How do you handle screening for patients that are able to speak a particular language but cannot read that language?
If they are truly not able to read it, then again, then I think you can do a verbal screen, as long as you think about a little bit how we do like screening for interpersonal violence. Can we get the client alone for a moment? Can we walk with them maybe into the bathroom if we have to? And then I would give them, I would read them to them exactly as written. I would not put any of my own verbiage. I would try to be very, very much try to just read it. And, that's about the best we can do with that situation. Yeah. But that's one thing I will say, folks who who may have literacy challenges, having a shared decision-making tool with some sort of visuals can be nice. Like if you've got like, a visual of medication and a visual of like 2 people talking, like a therapy, you can sometimes keep that in mind too, like reading level and literacy with which tool you might choose.
All right, well, our time is pretty much up. So thank you so much for Dr. Schaeffer for a wonderful presentation. And thank you all for joining us. It's really been nice to have you with us, spend a little time during Nurse Midwifery Week.
Excellent. Well, it was very wonderful to talk to everybody, and good luck. Add to your scope. It's a good thing to do.
All right. Thanks so much, everybody. Have a good night.
Great to see everybody. Okay. Bye-bye.